Ladies and gentlemen, we now commence the afternoon session, starting off with the 11th Symposium on Interstitial Lung Diseases. I invite the chairpersons, Consultant Respiratory Physician Dr. Amita Fernando and Consultant Rheumatologist Dr. Gunendrika Kasturiratna to introduce the speakers.
Good afternoon, everyone. Welcome to this symposium on interstitial lung disease. We have a wide spectrum of topics on interstitial lung disease and eminent speakers overseas. So on behalf of the College of Pulmonologists, may I warmly welcome all of you all and our eminent speakers from overseas. So the first talk is going to be on challenges in the management of hypersensitive pneumonitis. And we have got Dr. Peter Saunders from the UK. Dr. Saunders is consultant in respiratory and medicine and interstitial lung disease. He's from the Oxford University Hospitals NHS Trust, United Kingdom. Over to you, Dr. Saunders.
Hello, my name is Peter Saunders. I'm a chest consultant with a specialist interest in interstitial lung disease from the Churchill Hospital, Oxford, in the United Kingdom. And I want to thank the organising committee for giving me the chance to talk to you about hypersensitivity pneumonitis. I'd like to start with an overview of my session. First of all, I'd like to talk about the pathophysiology and presentations of hypersensitivity pneumonitis. I'd like to take you through the diagnostic workup for the disease, including the history, the role of antigen testing, how important imaging is to us, and of course, the possible role of biopsy. And then I'd like to talk to you about how I manage these patients, both with immunosuppression and now, thanks to the era of progressive fibrosis, how we use the antifibrotic agents in these patients. So in terms of what a diagnosis of hypersensitivity pneumonitis means, I'm sure many of you look after these patients and would recognize this idea of an abnormal immune response to an inhaled antigen, creating inflammation in the lung, and the idea that the individual has to be susceptible. This is not a disease that affects everybody who's exposed to the same antigen. The disease affects both the alveolar space with an impact on diffusion capacity and small airways in addition, which can give rise potentially to symptoms of cough, and that most of the antigens that are recognized to cause this disease are either fungal or avian. Of course, some antigens are very specific to the patient's workplace. And a nice example of this is metal workers who have a fluid that gets contaminated with a mycobacteria and can cause a very specific occupational lung disease. An accurate history, therefore, is really important to be able to identify what it is the patient's breathing in that is causing this abnormal immune response. Because, of course, in an ideal world, we want the patient to avoid the precipitant, and that should prevent further disease progression and hopefully improve their symptoms. In terms of the histories you get from patients, cough is often a feature, and the cough is often more distressing than that of idiopathic pulmonary fibrosis. Timing of exposure to a putative antigen can be helpful. A very nice history is one that comes on after acute exposure and is often associated with systemic features like myalgia or fever. But I find those cases are a lot rarer, and the more common thing is a subacute presentation, potentially hours to days after exposure, or even a chronic presentation where the timing of exposure seems to be very difficult to tease out in relation to symptoms. An example of this might be a patient who is exposed to feathers through feather bedding or feather cushions in the household, where what the patient reports is progressive breathlessness and cough over a prolonged period of time, and the exposure is a regular one, and therefore the bearing of symptoms to exposure is less clear. This is one of the cases where a really detailed occupational history is important, and for many jobs it's not good enough to know what the patient did as a job title, but more exactly what they did as part of their role. Ask about pets, particularly birds. There seems to be a lot of patients in Oxfordshire who look after parrots, which are a particular offender when it comes to avian HP. Ask about feather bedding. In the UK, it's quite common that high-end bedding is a goose eiderdown, and of course, this is full of potential antigen. Ask about hobbies, the person who is using model glues or paints, the person who is using lots of compost on the garden, which may be laden with mold spores. The examination often reveals quackles. The classic squawks are said to be more specific for HP. These are usually heard anteriorly, but they may not be present in fibrotic or chronic HP. HP is a genetic disease, I would counter. There is a susceptibility that inherently makes it more likely for somebody to get it. And unsurprisingly, as with many of our lung diseases, MUC5B, which is a constituent of human mucus, the gene that codes for it has a promoter polymorphism that affects 1 in 5 of the Caucasian population, and telomere length. So telomerase mutations, potentially early short telomere syndrome, have been found to be more common in patients with HP than those in healthy matched controls. Antigen testing is, I think, quite a difficult area. Whenever I go to a conference, particularly the ERS, I'm always struck by the number of posters about HP from different tertiary level centers that suggest nearly all of their patients are well characterized as to which antigen caused the HP. And I would say in the UK, my experience is that maybe only 30 to 40% of patients at best are we able to find a specific antigen that is positive in them. So I think testing, in my view, ought to be tailored to a patient's history. Most centers will have a routine batch of IgGs that can be offered. In my center, we have 3 avian species. We have Aspergillus and we have M. fini, which is, of course, an important cause of farmer's lung. And that's about it. The ATS and CHEST guideline from 2020 suggests that routine testing of IgG is important and can help differentiate HP from other interstitial lung diseases with a sensitivity of 83% and a specificity of 68%. Thus, the recommendation is weak. And my own view is that history is probably more important than a positive IgG. Radiology is what most of us will use with a history to clinch the diagnosis of HP. And I'm showing you here two scan slices from the same patient, one in inspiration, one in expiration. And this scan, I think, shows very nicely the 3-density or head cheese sign that's talked about as being classic of non-fibrotic HP. So there's ground glass. I think this is much more obvious on the expiratory scans, but even on the inspiratory, I hope that this projects well, that there's a diffuse ground glass. There's mosaicism, there's areas of dark and light lung next to each other, and there's lobular sparing. So there's some beautiful lobules, which I hope my pointer is showing to you now, of dark lung, which are spared from this disease process. This scan, I hope, projects that there is actually quite a lot of nodularity to the ground glass, and these are central lobular nodules that are classic of non-fibrotic HP. The distribution of disease is usually sparing the lung bases, but can be very diffuse. A lot of the disease we see, however, is more chronic fibrotic disease. There's peripheral reticulation, which can be fairly coarse. There's traction of peripheral airways, i.e. there's a genuine sign of fibrosis. There may even be honeycomb cyst formation, something perhaps we more typically think about in the UIP pattern of fibrosis. The distribution, however, rarely shows the basal dominance that IPF does. It's often more random. It can spare the bases again and often has a mid-zone dominance. Ground glass opacification and air trapping best seen on expiratory cuts. This is an inspiratory cut. You can see the trachea is nice and round. Those might give you a clue that this is HP, not IPF. And I think on this scan, you can see here some lobular sparing and these more diffuse patches of ground glass to show that this is less likely to be idiopathic pulmonary fibrosis. I have to say, in my particular centre, and I think across the UK, surgical lung biopsy is getting rarer and rarer in tertiary centres. And it's because I think the role of CT has become far more important. Cryobiopsy is performed in the UK, but not with the exuberance of some of the centres in mainland Europe. And so in my own centre, we tend to perform bowel, although during the pandemic, clearly this was harder to do, and so many patients didn't even have bowel. If you look at a typical lung biopsy in HP, you'll see airway-centric inflammatory change, which is often lymphocytic. You'll see the classic poorly formed non-necrotizing granulometer and a cellular bronchiolitis that may have lymphoid aggregates and foamy macrophages. So those are the typical features. But as I say, I think in the UK, we have moved firmly away from surgical lung biopsy, and I think partly driven by the poorer outcomes in patients with a UIP pattern that surgical lung biopsy offered. This table is taken from the ATS 2020 guideline and shows the typical features of a non-fibrotic HP, the features of a probable HP, and pathology features that are indeterminate for a HP. As I said, in my centre, and also true at the Royal Brompton, bronchiole lavage is a helpful tool, I feel, in these patients, and lymphocytosis of above 20% in my mind is relevant in helping to differentiate between CHP and IPF. In the ATS 2020 guideline, they talk about a lymphocyte count of greater than 40% having a sensitivity of 69% and a specificity of 93% at differentiating between CHP and IPF. Unfortunately, though, bowel lymphocytosis doesn't really help us differentiate between HP and sarcoid, and often this is the main differential in the case of fibrotic HP. Several papers have described that a higher level of lymphocytosis may be associated with a better prognosis in the long term. This table comes from the ATS 2020 guideline for diagnosing HP, and it brings in this idea of how confident we are of a diagnosis. And I like this as a concept because very typically we might have a case that comes to MDT where we're not sure. There's a differential of things that could be the diagnosis. We want a working diagnosis to allow us to treat the patient. So we might make a working diagnosis of HP based on a story that is compatible in terms of an antigen, a CT that is compatible, and then that we don't have any histopathology. And we can say, look, we think it's HP, but with a low to moderate confidence. And what that means is when the patient perhaps doesn't have the treatment response that we were hoping for, we have the ability to revise the diagnosis, to re-image the patient, to look again at the case and to say, look, it looked like HP to start with, but the way this disease has behaved over time is more consistent with IPF. It gives us a get out of jail card in terms of changing diagnosis in the future. Clearly, if you have a CT scan that's typical with an exposure history, a positive IgG test, and very typical pathology, that is going to be a definite diagnosis of HP. But I think there's so many grey cases where it's useful to have this idea of confidence in the initial diagnosis that allows us to revisit the diagnosis of behavior of the disease in the future changes. I think most of us will have had experience of using prednisolone as the initial management of a patient with hypersensitivity pneumonitis. It being an old and cheap treatment, of course, nobody's done very big trials to look at whether it actually works or not. And this is where experience-based medicine comes in. The one trial I could find that really did look at steroids and their role in HP was actually a pediatric paper published in 2011, in which there was a very well-characterized cohort retrospectively of 73 children who'd had a surgical lung biopsy and gone through MDT discussion in a specialist center. And these children were treated with monthly pulses of methylprednisolone. And what the study showed was that at 3 and 6 months that the gas exchange in these patients improved, but never fully normalized, despite often full symptomatic resolution of disease. Prednisolone is a horrible drug long-term. It's got multiple side effects, significantly increases cardiovascular morbidity, which is very relevant to the older populations we're usually treating, and of course is associated with excessive mortality in addition, even at lower doses of 5 milligrams. My personal practice is not to start patients on doses higher than 40 milligrams of prednisolone, and I try and get patients below 10 milligrams if I have to use prednisolone long term. I reserve methylprednisolone for only severe disease. Most commonly, I will try and use mycophenolate as a steroid sparer and aim to use it as long-term monotherapy in patients. The problems with mycophenolate is that it doesn't work quick enough. So I think starting patients on steroid with an aim to move over to mycophenolate is a better tactic. And mycophenolate very rarely gives the improvement in cough that steroids do, which for some patients is absolutely key to making them feel better. Mycophenolate's a prodrug undergoing hepatic metabolism to mycophenolic acid, which inhibits purine synthesis required for the clonal expansion, and it's very specifically hitting T and B cells rather than being more generally myelosuppressive. There's no randomized controlled trials in HP, multiple retrospective studies, though, suggesting a steroid-sparing effect and that it's associated with improvement in lung function over time. And generally in HP, I'm not using doses larger than a gram BD. Azathioprine was very popular in the UK for HP, but is now somewhat less commonly used. It again is a purine synthesis inhibitor, but it's much more myelosuppressive than mycophenolate. Again, it's a prodrug, and of course there is genetic polymorphism in the enzyme required for breaking down azathioprine. And so if you have reduced or absent activity of TPMT, you're more likely to get myelotoxicity. And so in the UK, it's routine practice to test TPMT activity prior to starting a patient on azathioprine. This is the bit that I worry about most, I think, when using azathioprine as a treatment for ILD, is that it's a known carcinogen. And I've had several cases of squamous cell carcinomas that often become metastatic in patients on longer-term azathioprine. The usual target dose of around 3 milligrams per kilogram. So this really, in my mind, is now second line to mycophenolate and not a drug I would use first line. Here are 2 trials that look at reporting retrospective outcomes, and you'll see the cohort sizes are very small for experience of azathioprine and mycophenolate. And both show really that the role of these drugs is in that they help to improve lung function that has previously been declining prior to their introduction. And in the UK study, that mean steroid doses were significantly lowered by almost 50% by using one of these drugs. This was a study that I presented at the ATS from the Royal Brompton Hospital in my time there, of a year's worth of cyclophosphamide prescribing in severe interstitial lung disease. And the message from this paper really is that outside of a well-defined connective tissue disease, cyclophosphamide did not seem to stabilize disease. And in the case of HP, and the numbers are small, and remember these were patients with severe disease at outset, but that cyclophosphamide seemed to be associated with an increased risk of mortality and did not stabilize lung function. And so the message I took from this was not to use cyclophosphamide in these patients. And of course, since my time at the Brompton, I started there in 2014, the idea of a progressive fibrotic phenotype has been well described now, both by Toby Marr and colleagues internationally. And we have the results of the INBUILD trial. INBUILD took patients with progressive fibrosis, those who had declining lung function despite previous treatment, and tried nintedanib, an antifibrotic that had previously been used for IPF. And this cohort of patients, there was a good representation of those with chronic HP, with a quarter of the study population essentially having that diagnosis. And INBUILD shows that nintedanib convincingly slows the decline in lung function over time. So in the UK, nintedanib is the only antifibrotic licensed for progressive fibrotic HP. The usual dose is 150 milligrams BD, but up to a third of patients won't tolerate that dose, and a lower dose of 100 milligrams BD can then be trialed. Side effects are really common. They include diarrhea that is almost universal, weight loss, particularly in those who are underweight already, LFT derangement, and abdominal pain. And in the UK, this is a high-cost medication at the cost of around $2,500 a month, with the need for ongoing blood monitoring that clearly has another health resource impact. Pirfenidone is not licensed for this indication in the UK, but the RELIEF study performed in Germany in 2020 did look at its use in progressive fibrotic lung diseases. And again, this cohort was enriched for HP and did show efficacy of pirfenidone over placebo. However, the study was terminated prior to its specified endpoint because of slow recruitment. Generic versions of pirfenidone are now available, and in some markets are lower cost, and therefore I think this is a reasonable drug to use in progressive fibrosis associated with HP. But again, side effects are common, and perhaps the most limiting one in a hotter climate than the UK is photosensitivity, but nausea and weight loss are also common. Factors associated with a better outcome include bowel lymphocytosis, fever at presentation associated with antigen exposure, central lobular nodularity, and a gain in lung function with immunosuppression. The presence of fibrosis on CT scan at outset predicts a worse outcome, along with bowel eosinophilia. So in concluding remarks, HP can have a variety of presentations, from an acute process strongly associated with antigen exposure to a progressive fibrotic disease in which no clear history of antigen exposure is elicited. There's a lack of trial data to support immunomodulatory therapy in HP, and trial design really is hampered by the wide range of HP presentations, making it hard to decide which patients to put into trials. And in chronic HP, my own concern is that there's a risk of poor outcomes associated with overexuberant immunosuppression. And for the future, treatment with antifibrotics is going to become wider spread, and this may help us improve outcomes in the subset of patients who have fibrotic disease. And I'll finish my talk there, and thank you very much for your attention.
Thank you, Dr. Saunders. Do we have Dr. Saunders online? He's online, is it? Yes, he's going to stay for the questions till last, or we want to take questions now? Till last?
Is it possible to do them now?
Last, okay. So we'll move on to the next speaker then. Thank you.
Yes, the next lecture in this symposium is Pulmonary Manifestations in Autoimmune Diseases by Professor Elisabeth Benstrup. She is a professor, senior consultant at the Department of Respiratory Diseases and Allergy, Aarhus University Hospital, Denmark.
Good afternoon, everyone, and thank you very much for the kind invitation to talk at your pulmonology meeting. My name is Elisabeth Benstrup. I'm a professor in respiratory medicine in Denmark, and I would like to express my gratitude also to Professor Rini Ravini for inviting me today. And I'm going to talk to you about pulmonary manifestations in autoimmune diseases. And these are my conflicts of interest. First, a few words on the background of autoimmune diseases in pulmonology. Approximately 20% of all interstitial lung diseases do have a background of an autoimmune disease. And ILD can be the only manifestation of the autoimmune disease, as is, for instance, seen in PL7 and PL12 polymyositis. Very often, autoimmune disease ILD carries a quite high morbidity and also high mortality, and is more often in women, mostly middle-aged women before the age of 60. Any pulmonary manifestation can be seen in any connective tissue disease or rheumatoid arthritis disease, but there are different frequencies. For instance, interstitial lung disease are most likely in scleroderma and also in inflammatory myopathies, whereas it's unusual in systemic lupus erythematosus. Also, as you will notice here, there are also differences in the frequency of different ILD patterns. Like, for instance, in scleroderma, NSIP is more common than a UIP pattern, and vice versa, more or less in rheumatoid arthritis, where the UIP pattern is more common than the more inflammatory patterns like NSIP, organized pneumonia, and so on. Pulmonary hypertension, likely in scleroderma, likely in mixed connective tissue disease, but unusual in most of the other autoimmune ILDs. Airways disease, common in rheumatoid arthritis and Sjögren, possible in mixed connective tissue disease and in lupus, but unusual in inflammatory myopathies and scleroderma. And also pleural diseases, pulmonary vascular diseases, and diffuse alveolar damage are more likely in some of the forms and less likely in other of the forms. You can say that certain types of autoimmune ILD can develop a progressive phenotype, and to establish the phenotype is the key. So if you have the group of autoimmune ILDs, some will become fibrotic but will remain stable and non-progressive. But a minor group of these patients will progress but maybe respond to therapy, at least in the long term, and some patients will have progression regardless of the treatment considered appropriate for the individual ILD. This is from the most recent guideline on progressive pulmonary fibrosis, where the frequency of a progressive phenotype in different autoimmune ILDs were developed by consensus amongst the panel members. And you can see here that scleroderma ILD and rheumatoid arthritis ILD are more commonly having a progressive phenotype compared to, for instance, lupus and also Sjögren's and myositis. So what about treatment of autoimmune diseases in pulmonology? Well, immunomodulation has been and is still the mainstay of treatment for all the autoimmune rheumatic diseases, although there are no randomized controlled trials, except for scleroderma ILD, but trials are being established in the other forms. Corticosteroids are still a mainstay of therapeutic strategy, again, except for SSc ILD, but can result in renal failure if you treat with high-dose steroid. There's low evidence for immunomodulatory treatments in all CTD and rheumatoid arthritis ILD, and also have to consider pulmonary fibrosis can be an adverse event of immunomodulation, but this should be cautiously interpreted. There are different strategies of a treatment, and I like also to say that MICO, which is a strategy I learned from Professor Wells in Brompton Hospital in London, is a useful strategy, and MICO means masterful inactivity with a cat-like observation. Or otherwise, you should really monitor your patients carefully, but you should not treat before there is a need of treatment. What you can use then is immunomodulatory treatment or maybe antifibrotic treatment. We should always remember to treat patients with palliative and supportive care. We should always look out for comorbidities, diagnose and treat comorbidities when needed. And finally, for a minor group of our patients, lung transplantation will be the correct decision. So if you look at the autoimmune ILD phenotypes, first of all, you will make the diagnosis of an autoimmune ILD, preferably at a multidisciplinary team discussion. Then you would like to establish the baseline severity of the disease, so you can monitor the disease in the long term. You could use symptoms monitoring, pulmonary function test, HRCTs, maybe also a 6-minute walk test. Quality of life questionnaires, hospitalization, adverse events are all signs of possible progression. So after following your patients, you can sort of make a phenotype. Is this a patient with a stable disease, or is it a patient with a more progressive phenotype? And what do we mean about progression? If you look at previous trials, what do we mean by progressive pulmonary fibrosis? Different trials have been identifying the progressive phenotype in different ways with different time spans from 6 months to 24 months, but also with different lung function barriers or limitations, and also some are involving symptoms and other are involving imaging. In the recent guideline from May last year, it was finally defined in a guideline what pulmonary progressive fibrosis is. And this is in a patient with ILD of non-unknown etiology other than IPF with radiologic evidence of pulmonary fibrosis. PPE should fulfill at least 2 of the following 3 criteria within the past year without no alternative explanation. So criteria number 1 is worsening respiratory symptoms. Criteria number 2 is absolute decline in either FVC within 1 year or DL0 more than 10% within 1 year. And criteria number 3 is different radiological signs of progression like increased extent, increased fibrotic features like more reticulation, more coarseness, more traction bronchiectasis, or new increased honeycombing, for instance. So if you have a progressive disease, you will have to discuss at your MDT, would you like to treat patients with immunomodulatory, anti-inflammatory treatment, or is it more like a clean or mixed fibrotic pattern? Maybe you will then go for an immunomodulation combined with antifibrotics, whereas if it's a sole inflammatory pattern, you will rather go for immunomodulation, preferably again based on MDT with rheumatology. So, what do we know about scleroderma ILD, SSc-ILD? Well, first of all, we know that SSc-ILD over the last 20 years has become the #1 killer in scleroderma and is now a more serious organ manifestation compared to, for instance, renal insufficiency, which used to be the #1 killer many years ago. We also know, if you look at the figure on your right, that at baseline, 50% of all patients with SSc has a degree of ILD at baseline. Majority has less severe changes, but a significant proportion has more than 5 to 10% of ILD on the HRCT at baseline. However, not all patients progress with the same speed. If you look at complete cohort of SSc-ILD patients on panel A, you can see it's sort of stable. But if you sort of differentiate between survival, you can see the long-term survivors, there's medium-term survivors, and also patients with short-term survival. So how can we find those that are rapidly progressive at the beginning, at baseline? We do know from a study almost 15 years ago from Brompton Hospital by Nicole Go that if you look at the HRCT extent at baseline and it is less than 20%, you could call it limited disease. If it's more than 20% extensive disease, if you cannot decide, you add FVC below or above FVC 70%, then these 2 groups will very, very nicely distinguish between 2 different trajectories. But besides the HRCT extent, other risk factors are useful, like male sex, active smoking, or older age of presentation, which sort of is risk factors for progression. Digital features related to the SSc disease, physiologic imaging, and also biomarkers like fractional excretion of nitric oxide, interleukin, and also C-reactive protein. We do have some evidence for treatment in SSc-ILD. We do have the Scleroderma Lung Study 1 and 2. Scleroderma Lung Study 1 investigated treatment with all cyclophosphamide versus placebo. There was a very nice signal with improved pulmonary function within the first 18 months, but after 2 years, there was absolutely no difference between placebo and cyclophosphamide-treated patients. In Scleroderma Lung Study 2, mycophenolate mofetil was compared to cyclophosphamide, and contrary to Scleroderma Lung Study 1, an improved FVC was maintained also after 2 years. This is a recently published study, the RESPIRE study, which was a phase 2b double-blind double-dummy trial investigating intravenous rituximab versus intravenous cyclophosphamide in patients with severe or progressive CTD-ILD. And it was a standard treatment protocol of rituximab here, and also cyclophosphamide was administered for 6 months. And what you can see is that scleroderma was 40% of patients and MCTD was 15% of patients. So this was a mixed group of patients. Nevertheless, in the group that received cyclophosphamide, there was more adverse events than in those who received rituximab. And if you look at the right, there was no difference between the two groups with respect to rituximab FVC decline, cyclophosphamide FVC decline. So cyclophosphamide rituximab seems to be equally good, but fewer side effects related to rituximab. The Census study some few years ago investigated the effect of nintedanib on FVC decline versus placebo. Here you see the overall results. There was a significant reduction in the FVC decline over 1 year in the nintedanib treated group. And this study was pre-stratified according to also patients who were taking mycophenolate in baseline. And even in those patients that were taking mycophenolate, you see there was even a larger inhibition of the FVC decline. But these two orange groups are those that were purely on clean placebo, placebo MMF, placebo nintedanib. And here you see mycophenolate, placebo nintedanib. And also here you see the signal that mycophenolate is beneficial in these patients. The FOCUS-HEAT trial was published a few years ago too, was mostly focused on the skin involvement, but they also collected FVC data. And these were early scleroderma patients with more like an inflammatory phenotype. And very nicely, but also a bit surprisingly, patients on tocilizumab had nicely stabilization of the pulmonary function compared to placebo patients, both in all participants and also in patients with SSc-ILD. The LOTUS trial is an open-label phase 2 trial that investigated the safety and tolerability of another antifibrotic called pirfenidone in SSc-ILD, and in a conclusion, pirfenidone was generally well tolerated and was also tolerated together with mycophenolate that did not affect tolerability. I had hoped to show you results today, but they're still pending, and hopefully we'll see them later on this spring. There are many other targets of approved and recently evaluated therapies in scleroderma, so hopefully in the future, even in the near future, we might see new drugs approved for SSc-ILD. But to sum it up, if you have an SSc-ILD patient that shows an early or inflammatory a disease type, you should go for mycophenolate, cyclophosphamide, tocilizumab, and maybe also rituximab in an MDT with your rheumatologist. If it's more like a fibrotic or combined fibrotic inflammatory pattern, nintedanib and/or mycophenolate. Then what about rheumatoid arthritis ILD? Well, here we know that several studies, I just shown 2 here, have found that a HRCT pattern of UIP has a significantly worse prognosis compared to other patterns, specifically NSIP. But there are other risk factors for progression here, like low FVC at baseline, smoking, and higher anti-CCP titers. This is a open-label, non-controlled, multi-center study on abatacept in RA-ILD, including only 63 patients. And you can see here that with respect to dyspnea, FVC, and DL show, there seem to be more patients with no worsening and some patients with improvement, and only few patients with worsening when treated with abatacept for RA-ILD. This study was followed up later on with a little bit larger observational multi-center study, including 263 patients that were followed for about 9 months. And again, you can see that dyspnea, FVC, DL show, but also radiographic changes seem to stabilize on the treatment. Some improved, and to some degree, others also worsened. Then there are a few studies with rituximab rescue therapy in ILD, again retrospective study in a minor group of patients, only 31, that despite standard treatment had progressive phenotype on steroids and DMARDs, and those patients got 2 cycles of rituximab, just like in the recital study. And again, you see some sort of a signal that majority of patients either stabilized or improved, but again, a group of patients also suffered from worsening. Methotrexate has been controversial for many years. Is it a friend for RA-ILD, or is it causing side effects, adverse events in the lungs? So this is a very nice retrospective study some years ago in 78 RA-ILD patients, where it's very clearly shown that those who got methotrexate had improved survival with respect to RA-ILD opposed to those who did not get methotrexate. And in a recent case control study, again, the association with methotrexate exposure was investigated in RA-ILD and patients with RA-no-ILD. And again, it seemed like methotrexate use was not associated with increased risk of RA-ILD. On the contrary, ILD was detected later in MTX-treated patients. Finally, this study was just published a few weeks ago. This is a multi-center Canadian study looking at pulmonary function trajectories before and after initiation of DMARD treatment, methotrexate, azathioprine, or rituximab. The red line is the measured pulmonary function, and the dotted line is the expected continuing pulmonary function without treatment. And here you see that introduction of DMARD nicely changes the pulmonary function decline with respect to both FVC and DLCO. Surprisingly, this was true both in non-UIP pattern RA-ILD and also in UIP pattern ILD. There didn't seem to be any difference between different immunomodulatory drugs here. RA-ILD has also been treated with an antifibrotic, nintedanib, in the INBUILD phase 3 trial. And here you see in the overall population in the INBUILD trial a very nice relative reduction in FVC decline with nintedanib. And also, if you looked at different disease entities within the overall group, there was no difference between autoimmune ILDs and the other different forms of an ILD. This is the recent TRAIL study investigating pirfenidone versus placebo in RA-ILD. The primary endpoint was decline in percent predicted FVC by 10% or more and was not met due to early termination of the study because of slow recruitment, probably also and definitely also due to the COVID pandemic. But nevertheless, if you look into secondary outcomes, there are also signals in decline in FVC, both in the absolute volumes and also in percent FVC. So if you look overall at treatment possibilities for RA-ILD, I would again say that if it's an inflammatory phenotype with progression, you would go to either start or continue methotrexate at either rituximab or abatacept. If it's a more fibrotic pattern, you would go for the antifibrotic treatment with nintedanib. But I have to stress at the moment there are no formal guidelines or consensus statements for RA-ILD. Then what about other forms of autoimmune disease-related progressive fibrosing interstitial lung diseases? Well, first of all, studies have shown that these patients have similar decline in 1 year in the FVC as patients with IPF, as you see here, patients with non-IPF ILD, and on the left, patients with autoimmune-related disease ILD. If you look at the different types involved in the INBUILD study, you can see here that about 1/4 of patients had a connective tissue disease ILD, including rheumatoid arthritis, which was half of this group, but there were also other forms of autoimmune rheumatic ILDs in the study. But nevertheless, looking only at the autoimmune disease-related ILDs, similar pattern is seen here with a relative reduction of FVC decline, almost 60%. And this reduction was found nevertheless when patients were treated with DMARDs or glucocorticoids in combination or one or the other. Again, if you stratified according to different types of autoimmune diseases, take caution that the numbers of patients are very small. There was no different signal here. And also, if you looked at decline over 1 year, there didn't seem to be any large differences between different forms of autoimmune ILDs. So, in conclusion, ILD is common in patients with autoimmune rheumatic disease, and we need to look out actively for it. A subgroup of these patients will progress over time and will have increased morbidity and mortality. Randomized controlled trials in SSc-ILD have now resulted in consensus statements for the treatment of SSc-ILD, but there's a huge lack of randomized controlled trials and treatment algorithms in other autoimmune rheumatic diseases. And with these words, thank you very much for your attention, and I wish you a very nice continued meeting in Sri Lanka. Thank you very much.
Thank you very much, Professor Benstrop. So we wish to meet you again in the Q&A session at the end of this other two lectures.
It's my pleasant task to introduce our next speaker, who is Dr. Will Fong. Dr. Will Fong is from the USA. He's a professor in medicine, rheumatology, and critical care. He is from Vanderbilt University Medical Center, USA, and he would like to base his talk on some case discussions in connective tissue-based ILDs.
Hi, my name is Erin Wilfong, and I just want to thank the organizers so much for giving me the opportunity to speak with you all. I apologize for the fact that I'm not there in person with you, and this had to be pre-recorded due to time zone issues. But I'm excited to share with you the talk today that's a case-based approach to connective tissue disease, ILD. Oops, sorry about that. These are my disclosures. So the goals of this talk is to kind of talk through some practical challenges related to CTD-ILD as well as the IPAF diagnosis. I'll provide some insight into how I think about diagnosing and managing these conditions. And it's important to note that the goal is not to be comprehensive. I'm sure that, there's an exception to every rule, but the goal here will kind of just be to touch on a few subjects. So the first case that we'll talk about today is a 51-year-old who's referred to me for possible CTD-ILD. She had a 5-year history actually of recurrent pneumonia and had already undergone a lung biopsy that was read out as either usual interstitial pneumonia versus desquamative interstitial pneumonia. She did have a 40-pack-year history of tobacco, but had quit 5 years prior to her biopsy. Given the presumed IPF diagnosis, she was enrolled in a clinical trial, but had failed to tolerate pirfenidone due to GI issues and neuropathy. And over the past 24 months, so 3 years from her ILD diagnosis, she's been developing worsening joint pain in her hands and wrists and now has 3 hours of morning gel. She endorses significant dyspnea on exertion and now requires supplemental oxygen. These are her images. What you can see is, as you can tell, honeycombing and areas of reticulation with minimal ground glass outside the areas of reticulation consistent with UIP. On exam, when I saw her, what was notable was that she had a lot of synovitis, lots of tenderness, lots of swelling in her hands and wrists. She had not had serologic evaluation initially and was found to be CCP positive, and her x-rays were remarkable for erosions. She did have, based on our ACR disease activity scores, an elevated, very high disease activity score by both metrics. And this was thought to be most consistent with RA-ILD. And this case highlights the fact that 10% of ILD cases can precede articular symptoms. So how do we think about RA-ILD? This is probably the most common cause of ILD that you see as a rheumatologist and a pulmonologist. And so how do we think about it? First off, multidisciplinary care is very important. The definition for RA isn't great. It just means you have joint pain in over 10 small joints that seems inflammatory for over 6 weeks. Lots of things cause that. So if everyone's convinced this is RA, and we'll talk about that more in a moment, the first question is, do they have active articular disease? If there's active articular disease, it must be treated aggressively, treat to target. If they're not progressing ILD, if they're non-UIP, more NSIP, like lots of ground glass, DMARD therapy may be beneficial there. If they have no articular disease, a UIP pattern, or they're progressing, that's when I think antifibrotics are really useful. And articular disease is important to treat because it actually affects mortality. This is a study of US veterans, and what they found is that the reference group is up here. This is normal FVC and low disease activity. If you start having active disease, you did worse. Irrespective if your PFTs were normal when you started, you did worse than if you had normal PFTs and no disease activity. If you had if you had impairment of your PFTs with active disease activity, you did worse than patients who had non-active disease. The other thing to realize is that methotrexate is not contraindicated in RA-ILD. This has been looked at in several studies. There was no increased risk in death. There was no increased risk in hospitalization for US RA patients treated with methotrexate. A UK cohort, actually, it looked like methotrexate may delay the ILD diagnosis. And there's a Mexican study that showed that RA-ILD survival improved with the use of methotrexate. So this medication is very good for RA. It's very inexpensive, and it can be used safely in many patients with RA-ILD. The next question is biologics. Are some biologics better? This part of the talk may be a touch controversial because there is no randomized controlled trial to underlay this. This is a retrospective cohort study that was multinational, but it was relatively small. The important thing to realize is that almost all biologics have a reported risk of lung toxicity. But in this study, they looked at patients who were started first on a TNF alpha versus anything else. The risk of progression if you were started on a non-TNF alpha, the odds ratio was 0.1. That was fairly convincing for me. The other thing to note here is smoking history has an odds ratio of progressing of 6.9. So our patients really need to stop smoking if they're still smoking. That will drive their RA-ILD. What data do we have for antifibrotics? 42 patients with RA-ILD were included in the initial in-build study of progressive pulmonary fibrosis, and there was a favorable benefit in terms of FVC decline. Pirfenidone, this paper actually just came out this month, looking at pirfenidone in RA-ILD. There was no endpoint in either death or FVC decline by 10%. This study was terminated early due to COVID. The patients on pirfenidone did have a reduced FVC decline, and the benefit was greatest amongst patients with UIP pattern. So how do I think about treating RA-ILD? First and foremost, I track CDAI and DAS28 and I treat to target. For patients with mild ILD, and to me, this is an FVC and DLCO of greater than 60%, I use methotrexate as first line. Based on emerging data that I just shared, I'm avoiding TNF inhibitors in RA-ILD and using more of our other biologics, especially abatacept and tocilizumab. I haven't used as much Ritux due to the COVID-19 pandemic. If patients are progressing, I'm using antifibrotics. And if they're on oxygen, I do refer for lung transplant. These patients usually don't have some of the GI comorbidities and other things that scare the surgeons off. So a lot of times RA-ILD patients, if young, will be reasonable transplant candidates. The other thing to realize is to consider a mimic if the CCP is negative. Lots of things can cause ILD and inflammatory arthritis, and rheumatoid factors are not specific. CCPs are pathognomonic for this disease. They're pathologic in all likelihood. If you have RA-ILD, you have to be CCP positive. If not, really think about what else is going on. All right, so going on to our next case. This is a 38-year-old female who came to me via the lung transplant clinic where she was referred for lung transplant. She works at an aluminum smelter and actually is frequently around the furnaces melting down the aluminum and does not always wear her personal protective equipment. She has an 8-year history of Raynaud's that's gotten markedly worse in the past year. She had her first ulceration. She has 1 year of progressive dyspnea and has been on oxygen for 3 months, but she doesn't wear it at work. She has 6 months of severe reflux with no prior history. She has RNA polymerase III positive. And on exam, although she doesn't have skin involvement, she does have pits, abnormal nail fold capillaries, telangiectasias, and meets classification criteria for systemic sclerosis. So this is her imaging. And what's striking here is how much ground glass there is. So unlike our last patient where it was all reticulation, this is mainly ground glass. There's some traction there, but it's 5-lobe involvement, not a lot of permanent scar. What data do we have for treating scleroderma ILD? Some of the best data is the Scleroderma Lung Study 2, comparing oral mycophenolate mofetil to oral Cytoxan. Both drugs were associated with improved FVC at 24 months, but MMF had fewer side effects. In the US, this has been interpreted as a positive study favoring the use of MMF in these patients, and it is standard of care. In some regions of the world, since there was no benefit of mycophenolate, it has not been adopted widely. And that'll be worth knowing in a second when we get to another study. The other medication that's FDA approved for scleroderma-associated ILD is tocilizumab. This study was actually designed with skin endpoints, but it was found to have a marked effect on decreasing the FVC decline compared to placebo. And so it's FDA approvals for ILD. Things to note is these patients were early. This is within the first few years of diagnosis. This is not long-standing scleroderma. And it seemed to work best in patients who had a lot of inflammation and elevated CRP, which makes sense for an anti-IL-6 therapy. So this is your other option for immunosuppression that's FDA approved. In terms of antifibrotics, the Census trial was looked at nintedanib and scleroderma ILD. And because of those geographic differences that we alluded to, functionally, these patients were stratified geographically to either receive or not receive mycophenolate, and then were randomized to nintedanib. So it's almost a 2x2 factorial design. And what this found was that there's a synergistic effect between nintedanib and mycophenolate mofetil. Either drug on its own works some, they work better in combination. So how did my patient do? Because of how much ground glass she had and that she was pretty early in her course, we actually treated her with MMF. I recommended against proceeding with a lung transplant evaluation. Today, I may have considered tocilizumab. She did have an elevated CRP when she was referred to me, and she was very early in her course. Her non-Raynaud's symptoms were really within the past year. With mycophenolate, she actually did remarkably well. Within 6 months, she had a 10% increase in her FVC, a doubling almost of her 6-minute walk, and an improvement in her DLCO, and she was off of oxygen. In her case, I did not start nintedanib because there was such a PFT improvement. But typically for any patient who doesn't have this type of dramatic PFT improvement coming off of oxygen, I do start nintedanib around the 3-month mark of being on background MMF. Why 3 months? I want to make sure the MMF is being tolerated, that I know if there's liver issues, which drug is causing it, if there's GI issues, which drug is causing it. So I do stagger those starts. All right. So moving on to case 3, this is a 46-year-old female with rheumatoid arthritis pneumonia who is referred to me for a second opinion. She is rheumatoid factor and CCP negative, and she's now presenting with worsening cough and intermittent fevers. She has been on prednisone over 20 milligrams a day for the past year, and on exam, she does have inflammatory arthritis. She has synovial proliferation in her hands and wrists, but she also has Gottrin's, mechanics hands, and an elevated CPK. So this is not RA-ILD, this is dermatomyositis. And even more interesting in this case is looking at her CT imaging. So on her CT scans, these are 3 periods of time over about 18 months, her infiltrates migrate. They're never in the same place twice. She has a little bit of stuff at the bases that I'm not showing you, but she keeps moving these dense consolidations around. And on the day that I obtained the CT scan related to this appointment, she has a new dense right lower lobe consolidation that we've never seen before. So given the fact that she had fevers, that she had been on immunosuppression for a long period of time, I was worried about an infectious process and took her to bronchoscopy with BAL. So when do I do a bronchoscopy? I do bronchoscopy when I'm struggling for, are you infected versus is this your disease? I don't find that BAL is helpful for diagnosing CTD-ILD over other causes of ILD. It's really for me to rule out infection. So this was a representative image for what her cytology would look like, and there's oil red O lipid-laden macrophages everywhere. On extensive questioning, she actually notes worsening reflux for the past 6 months and has a hiatal hernia, and so it looks like she's recurrently aspirating. So for her, yes, she has abnormal pulmonary function. Yes, she has a little bit of ILD in the basis. Yes, she has active dermatomyositis. But aspiration's her driving cause. And this is really the important thing about thinking about what else could be mimicking, lung problems or ILD in patients who are set up for it immunologically. Nissen fundoplication is associated with improved survival in IPF. The challenge in the CTD world is that you have to have a normal esophageal function. So it's less helpful in scleroderma, less helpful in myositis, but in the right patient, it can be quite useful. In this patient's case, she was found to have normal esophageal motility and underwent elective Nissen. and she had complete resolution of her CT findings. She's currently on mycophenolate, abatacept, Plaquenil, and 5 of Pred. For her dermatomyositis, her PFTs are essentially normal, and her dermatomyositis is in remission. And I want to point out with her immunosuppressive regimen that she's on combination therapy. I'm not going into the different combinations as much in this talk, given that it's a pulmonary audience, but most of my patients are on a small molecule. Some of them are on 2. I use a lot of mycophenolate and tacrolimus together, or instead of tacrolimus, they're on a biologic. So moving on to the last case that we're going to go through, this is a 67-year-old who initially presented to my pulmonary colleagues for evaluation of ILD. She endorses morning stiffness of less than an hour, so once she gets out of the shower and drinks her coffee, she's fine. She has no Raynaud's, weakness, rashes, or any other concerning symptom. Her CT scan does show honeycombing and some ground glass, but really in areas of reticulation. Her ANA was 1 to 320 speckled. We have gone to comprehensive serologies for every ILD patient and we're to catch all the synthetases. And so she was ANA positive, everything else was negative. And the question to me was, does this patient have IPAF and do I need to immunosuppress her? So these are the criteria for interstitial pneumonia with autoimmune features, or IPAF. And the thing I want to highlight here is these were research criteria. These were research classification criteria in 2015 to try to understand and identify which patients need trials of immunosuppression, who benefits if you don't meet a defined CTD. This was never designed for diagnosis. This was never validated for diagnosis. So while it can be a useful thought construct for things to think about for maybe my patient has CTD, these criteria should not be applied strictly. So in the clinical domain, what are these really looking at? They're looking for things like scleroderma and myositis. Serologically, ANAs and rheumatoid factors and CCPs are there, as well as the extractable nuclear antigens. We also have some of our myositis antibodies. Morphologically, a CT scan that's suggestive of NSIP or OP is usually what's going to be your morphologic domain. The thing to realize there is that half of NSIP CT scans are going to be UIP on biopsy. So this isn't perfect. And when applied thoughtfully, this can really help us understand outcomes in IPAF cohorts to try to understand who benefits, who doesn't, who do we treat, who do we not. And this is work from Justin Oldham in a multi-center study. And what they found is that IPAF patient outcomes, survival, what we all really care about, can be stratified by autoantibody positivity. If you have a myositis-specific autoantibody, antisynthetase, even MDA5, you do better. This line up here is myositis ILD. The one right below it is IPAF with a MSA. The myositis criteria are not great. They miss most antisynthetase and some either other myositis ILDs. The myositis-associated autoantibodies, so your COOs, your PMSCLs, your Rho52, since it's a Rho antigen, do better than IPF, but worse than myositis ILD. This is going to be your IPF MAA line is right here. Then what we're going to get into is your IPAFs. My cursor keeps going away. Sorry about that. Your IPAFs with no myositis or specific or associated antibody, and then IPF. So just stratifying based on those myositis antibodies can really predict outcome. It's also worth noting that a third of patients with biopsy-proven IPF had a positive serology and a Mayo series. So lots of ANAs, rheumatoid factors, CCPs. These are non-specific antibodies. CCPs are better, but ANA and rheumatoid factor especially are non-specific. And again, one thing I want to highlight here, this is just looking at UIP versus non-UIP. If you have a myositis-specific antibody, it doesn't matter whether you have UIP or not. You do well. Treat these patients. Do not tell them you have UIP, you're going to die in 2 years. Give them immunosuppression. This is if you have a myositis-associated autoantibody. If you have UIP, you don't do as well. So what is my approach to a patient with IPAF? First off, there's an exception to every rule. So this is a general approach, but I'm sure you could present me patients where I would deviate from this. Do you have a positive serology? And if so, Is it one that I really feel comfortable leaning on? Is it a synthetase, MDA5, COO, PMSCL? Rho 52s tend to not do as well if they don't have other symptoms. But those are patients I would at least trial immunosuppression. If it's a synthetase, I treat them very aggressively, or MDA5 or COO or PMSCL. If you don't have a positive serology, or you just have an ANA or rheumatoid factor, is there anything on exam that lets me hang my hat that this is right? Do you have, nail fold capillary changes? Do you have any skin findings, rashes? If you have arthritis, can you get an ultrasound to look for increased Doppler flow that'd be indicative of an inflammatory arthritis? If there's any of those things, probably reasonable to trial immunosuppression. If not, I tend to favor antifibrotics in those patients. In my last minute, I want to just highlight MDA5 dermatomyositis. This is by far the most lethal form of all CTD ILDs, and especially myositis ILD. And a lot of times you won't see this disease until it's staring you in the face, and you don't have a lot of time to recognize what you're seeing. So this is classically ulcerating Gottrins. These are the pictures in the textbook. What it'll start as is these tiny little ulcers on the knuckles. Do not wait for this to become this before you see it. This is pathognomonic for MDA5 disease. They also get palmar papules, so these vasculopathic ulcers on the palms of their hands, particularly at creases. Also pathognomonic. The interesting thing with this disease is that it is very interferon mediated. Calcineurin inhibitors are typically first line. There's decent data for rituximab. Tofacitinib is still early days. And there was one study in 2020 showing that cyclophosphamide plus TAC plus steroids, patients did better. That study was not age or sex controlled. On subsequent analyses in other groups, when they age and sex did propensity scoring, that effect was lost. So I do not do upfront combination therapy. So in conclusion, my general approach to connective tissues ILD, first, do they have what you're told that they have? Treat inflammation first and add antifibrotics if the ILD progresses despite immunosuppression or if they have scleroderma. For IPAF, you're really trying to see if they have subclinical CTD, especially myositis spectrum. Non-specific serologies are just that and can be seen in IPF and hypersensitivity pneumonitis. And I really encourage multidisciplinary management for these patients. And with that, I'll thank you for your attention, and I'll again apologize for the fact that I'm not there in person or to take questions due to the time zone, but I wish you all the best of the conference. Thank you.
So we move on to the last lecture of the symposium, Progressive Fibrosing ILD. This is done by Dr. Amila Ratnapala, Consultant Respiratory Physician at National Hospital, Kandy. Over to you, Dr. Ratnapala.
Thank you so much. And first of all, I'd like to thank the organizing committee and the president for the invitation. So today we are going to discuss about the progressive fibrosing interstitial lung disease and evolving evidence. And some of the key points has been discussed in the previous lectures as well. So first of all, I'd like to discuss few case scenarios with you all. A 57-year-old patient with seropositive rheumatoid arthritis on methotrexate. He's presented with progressive dyspnea for 3 months duration and diagnosed with RA-NSIP with moderate physiological impairment. And he was treated with, he was initially treated with methotrexate, but according to the previous practice, we discontinued this methotrexate and started on azathioprine for 1 year without any improvement. His symptoms progressed. And he has radiological evidence of progression as well as physiological evidence of progression. So these are patient number 1. And the patient number 2 is a 55-year-old lady with diffuse cutaneous systemic sclerosis as the interstitial lung disease, NSIP pattern, diagnosed 4 years back, relatively stable, but recently presented with progressive symptoms of shortness of breath for 1 year, and further evaluation revealed poor adherence for treatment. So how do you differentiate whether it is progressive pulmonary fibrosis or what are therapeutic interventions that we should consider in these patients? So I'll first discuss about the terminology, because there's huge confusion about this progressive pulmonary fibrosis versus fibrosing phenotype, because original research, the inbuilt trial, they have introduced the term of progressive fibrosing ILD, but later the ATCRS consensus statement came, renominated it as progressive pulmonary fibrosis. But anyway, there are some similarities and there are some differences as well. I'll discuss the pathophysiology and the definitions, therapeutics, as well as the management and their basis for the management. And these initial concept of progressive fibrosing ILD or pulmonary fibrosis with progression. And over the time, we found that most of the ILDs, they have certain cohort of patients which are tended to progress irrespective of the optimum treatment. When you consider these terms, progressive pulmonary fibrosis versus fibrosing phenotype, they share similar pathophysiology. So most of these patients, they have common genetic predisposition like telomeric attrition, MUC5B gene polymorphism, and mitochondrial dysfunction, followed with exposure to various antigens in cells. For example, antigen exposure in hypertensive neuritis and in autoantibody formation in CTD-ILD and microaspiration smoking in IPF. And they resulted in monocyte infiltration and fibroblast proliferation, which leads to progressive pulmonary fibrosis, which could be IPF in the classical form or other forms of pulmonary fibrosis. So do you have enough data to suspect this phenotype? Yes, we do have enough data. And can we diagnose this phenotype at the disease onset? At the moment, there's a lot of studies going on, but at the moment we can't. But there are a lot of biomarker studies as well as clinical and phenotyping and genotyping studies are going on to identify these cohorts who are tending to progress at the beginning of the disease. So there's huge confusion about this phenotype in the clinical scenario. Basically, that if I get this National Human Genome Research Institute, they say the phenotype refers to individual observed traits, actually, which are determined by their genomic makeup with the environmental interaction. So if you go for this American Journal of Respiratory and Critical Care Medicine, and if you go for the idiopathic pulmonary fibrosis and progressive pulmonary fibrosis treatment guideline, they're strongly discouraging to discuss about this phenotype, saying there's no particular genotype for this particular fibrotic phenotype that we are seeing in patients. But however, still there are genomic studies that are going on, but we are identifying more common genomic patterns in these patients. So I think soon we will find the genotype for this particular progressive pulmonary fibrosis. I think the definition has been discussed previously. This definition is not a research-based definition, but it is a consensus-based definition by the committee of ERS-ATS. So they found that two of these three criteria, if they are present, they consider it as progressive pulmonary fibrosis. First of all, that there should be worsening of respiratory symptoms. And second, there should be a physiological evidence of disease progression, either absolute decline in FVC more than 5% predicted within 1 year, or absolute decline in DLC more than 10% predicted in 1 year follow-up. However, you can see that if you go for the inbuilt trial, that they were more concerned about FVC decline more than 10% and FVC decline 5% with radiological or clinical progression. But FVC decline 5% over 1 year, it could be due to variability as well. So therefore, you have to be really cautious when interpreting these guidelines into a practice. And radiological evidence of disease progression as evidenced by increased extent of severity of traction bronchiectasis or bronchialectasis and new ground glass opacity with traction bronchiectasis, new fine reticulation, and increased extent of increased causes of reticular abnormality or increased extent of the fibrosis and increased lobe volume loss. So these are the criteria, radiology criteria for the evidence of progression in a patient with progressive pulmonary fibrosis. And I think this slide has been discussed previously. There are certain percentage of ILDs, they present with more evidence of progressive pulmonary fibrosis. For example, highest number of patients that we see in this cohort is systemic sclerosis and followed by hypersensitive pneumonitis as well as rheumatoid arthritis. If you consider therapeutics, the role model for the therapeutics in progressive pulmonary fibrosis is IPF. And we know that inflammation or injury leads to fibrosis. There are so many clinical trials has been studying about these fibrotic mechanisms, and you can see so many molecules has been studied to treat this condition, and there's only few molecules has been succeeded. So, however, when you go through these molecules, that we have learned so many points which are relevant. Even there are negative studies, there are positive studies which are really relevant for our long-term understanding of this disease. So the first study I'm going to discuss is this PANTHA-IPF study, which has been published in 2012. It gave a very good lesson, the prednisone, azathioprine, cysteine for pulmonary fibrosis. And they have recruited about 300 patients, about 70 to 80 patients each arm. In one first arm, there's treatment arm in prednisone, azathioprine, and NAC. And then second arm is placebo arm, and the third arm is N-acetylcysteine alone arm. So what they found is, if you consider the outcome, the primary endpoints, the time to death, the time to death or disease progression, as well as time to death versus hospitalization, they were all increased in the treatment arm. Therefore, this study has been terminated initially, and they discontinued the treatment arm because they found that targeting the inflammation is not the therapeutic intervention for pulmonary fibrosis. If you go through the landmark trials, the first landmark trial is Iphigenia in 2005. They have given some impression that whether immunosuppression would work in pulmonary fibrosis, but then it has been proven, it has been further studied in PANTHA-IPF study, which they found that it is not the case and it increased the mortality. And then perfluorine molecule has been introduced to the world in 2005 in Japan, and then the Capacity 1 and 2 trials came in 2011, and then Ascent study came in 2014, and then Impulses came in 2014. So all this study has proven that the antifibrotics are the treatment option for fibrosis, not the inflammation. So we know that target for intervention is fibrosis, not the inflammation. So this is the first study with regard to PPF, which came into light in 2019. That is basically for systemic sclerosis, interstitial lung disease. I'm not going to go into more details because it's been discussed in detail. There are about 800 patients who are diagnosed with the systemic sclerosis for more than 7 years. And the most important fact is that these patients either had progressive pulmonary fibrosis or they were at risk of pulmonary fibrosis. So they have not included all the patients with progressive pulmonary fibrosis, but there are this mixed cohort of patients. But they are late in the disease spectrum. And then half of these patients was treated with nintedanib, and half of these patients was treated with placebo, and then later it has been analyzed. So we found that the treatment arm has significant reduction in the disease progression compared to the placebo, and this has been further evaluated that when we have combination of mycophenolate with antifibrotics, the disease progression is much more reduced compared to the placebo. The second landmark clinical trial is InBuild clinical trial, which they included patients with progression of their lung disease within 24 hours, despite the standard treatment. FVC declined more than 10%, and FVC declined with 5-10% with worsening symptoms and worsening radiology, and worsening symptoms and worsening radiology extent of fibrosis. So these are the subcategories of these patients. I would like to highlight the fact that most of the patients belong to hypersensitive pneumonitis or autoimmune disease, but none of these diseases has been adequately powered to study individual basis. So therefore, we need larger scale study with adequate power. So what they found is that nintedanib treated group, that they have the increase or actually the rate of decline in the lung function has been significantly declined. And if you go for the UIP pattern and non-UIP pattern, in both patterns, that their decline is significantly reduced with nintedanib use. And this is the third study I'm going to discuss. This is the perfluorine in patient with unclassifiable progressive fibrosis interstitial lung disease. It's a phase 2B trial, just been published in about 3 years back. And however, In this study, the primary endpoint was not achieved because they have used the home spirometry as a primary endpoint, and thus, as you can see, there's significant variability in the home spirometry compared to the previous study. So therefore, the primary endpoint was inconclusive. However, if you consider the secondary endpoints, that they found that it favors use of perfluorine in unclassifiable interstitial lung disease who are having fibrosing, progressive fibrosing phenotype. If you consider the recommendations, as you can see here, that the NICE recommendations are quite similar to InBuild. They recommend use of nintedanib if the patients have, if FVC decline more than 10% within 24 hours, or FVC decline more than 5% with clinical or radiological worsening of the fibrotic pattern. And then thirdly, if there's any clinical or radiological pattern of fibrosis in progressive ILD. So the NICE recommendations are quite similar to InBuild. And if you consider ATSDRS guidelines, they have a conditional recommendation for nintedanib, but they have shortened the duration of time from 24 months to 12 months, and they have reduced the FVC decline to 5% compared to the 10% in the original trial. So they have some, the committee has altered some of the decisions which has been highlighted in the evidence, and they have modified according to the expertise. And then they have suggested perfluorine actually as a very poor quality evidence. However, none of the committee members voted against use perfluorine in absolute conditions. Like, I mean, if there's no option that if you don't have an nintedanib, still you might use perfluorine, like in our setup in Sri Lanka. So in real life, if you come across a patient with progressive ILD, it is very important to exclude common things first. So first of all, as my in case scenario B, that most of the patients in our setup that they might have poor adherence. So therefore, it's very important to get the clinical history correct, where the patients are taking adequate amount of treatment and they are continuously getting followed up in the clinic. And then other common condition is CTEPH, which is chronic thromboembolic pulmonary hypertension, that you should always consider in a patient who is progressing over the time, and with their right heart echoes and CT pulmonary angiogram to see whether there's any evidence of a chronic thromboembolic pulmonary hypertension. And especially in our local setup, chronic infections are also common. So therefore, I think you have to particularly exclude chronic infections like tuberculosis or non-tuberculous mycobacterial infections, as well as they might have some other exposures which might lead to additional fibrosis. So always very important to get a detailed history and exclude these differentials before you come to a conclusion of progressive pulmonary fibrosis. And then you go through the HRCTs, and if there's any predominant fibrotic pattern which is progressing with the time, along with the physiology and the clinical criteria, you might label them as progressive fibrosing phenotype or PPF, and may consider antifibrotics depending on the availability. And if the HRCT shows mixed inflammatory and fibrotic pattern, you can discuss at the multidisciplinary meeting and then decide whether to continue immunosuppression and add on therapy with antifibrotics. But if the HRCT is predominantly inflammatory, in that case, again, you have to exclude common things like infections, and then you might have to escalate the immunosuppression pathway. So this is a diagrammatic summary of progressive ILDs when you are dealing with in your real life clinical practice. And if you consider the future direction, still there's a lot of arguments going on whether upfront chemotherapy or upfront antifibrotic therapy versus sequential antifibrotic therapy, but still none of conclusive evidence is there at the moment for either start upfront antifibrotic therapy or sequential antifibrotic therapy. So at the moment, the standard therapy is sequential antifibrotic therapy. And also phenotyping and genotyping to identify PPF at the disease onset. That is one of the major factor, because if you can identify these cohorts who are tended to progress, in that case we can consider these antifibrotic therapy early and prevent their disease progression. And also these acute exacerbations of these patients who are having PPFs are quite common, and they have very high mortality, about nearly 50% mortality in this cohort. So therefore, it is very important to identify these factors, and there are a lot of research going on these directions. And I'm happy to answer if there's any question, and thank you so much for the invitation. Thanks.
Thank you, Amila, for that excellent presentation. Do we have any of our speakers online? It's Dr. Amila, or is Dr. Saunders also there online? Unfortunately, again, let me thank on behalf of my co-chair and the, our college. We have Dr. Saunders online? No. So let me once again thank our speakers for excellent sessions on interstitial lung disease. We have Amila online, so I'm sure Amila will be happy to share its experiences. Amila is also currently in the UK with the audience on any of their questions they have on any of these topics.
Thanks, Dr. Amila, for covering an excellent topic. And you mentioned that about the upfront use of an antifibrotic therapy. That is currently there is no evidence. But my thought is that if you look at the natural history of fibrosing ILDs, so it is said that out of all fibrosing ILD, there is 35% of them will be progressive. And if you take chronic HP as an example, and according to the natural history data, the 60% of the chronic fibrotic HP will be progressive. So each 10% decline to characterize the progressive fibrosing ILD is considered to be increase the mortality by twice. And according to the NICE guideline, that when the FVC drops below 50%, and they are considered for palliation rather than immunomodulatory or antifibrotic treatment. So what are your thoughts at least in patients with chronic fibrotic HP, that when the natural history shows that 60% of them will be progressive, to start on an upfront antifibrotic therapy?
Thank you so much for this excellent question. And actually, as I said, there's no evidence for that. But the most important fact is that, I mean, if you diagnose chronic HP, that we should identify the etiology, what is the particular cause for that. And the most important intervention could be that removing the etiology for that particular chronic HP. And then, because that the tendency is actually, if you start treating all these patients with antifibrotics upfrontly and without going for a detailed history, detailed examination, and detailed evaluation of the etiology, you might miss certain steps which can prevent the disease progression easily. However, after excluding that, depending on the experience, actually, I mean, now this timeline for this definition of this progressive pulmonary fibrosis is getting low. For example, in the inbuilt, they have mentioned about 24 months, which is very long time. And if you go for the clinical guideline, they come to 12 months now, shortened. But in practice, at least I think you should wait for 3 months. I think most of the speakers would agree, my colleagues here, that at least we should offer a proper etiological assessment and then give adequate treatment at least 3 to 6 months before you consider antifibrotics. That is my personal opinion, but there are so many other counter arguments are going on, and there are studies going on whether this therapy is accurate. But at the moment, most of the experts, they try at least to give the disease-specific therapy for initial 3 months at least before starting antifibrotic therapy. Thank you so much.
Yes, John.
I have a question. I'm happy. It's about RA-ILD. I'm happy for Amila, even one of the chairpersons, to answer my question. So in RA-ILD, stable disease without any progression, somebody with intractable cough, what are our therapeutic options? And is there a place for antifibrotics in that instance?
Amila, would you like to answer that?
Yeah, thank you so much. And thank you, Shandimani, for that excellent question. Again, that antifibrotics with symptom management, there are very little data, but mostly that antifibrotics and symptoms, there's no much of connection. So I think if first of all, it's important to identify the cough, the reason for cough. Most of the patients with RA, that the reason for cough could be associated ARV inflammation, which might be effectively treated with inhaled steroids, or it could be due to microaspirations, which is very common in these patients with autoimmune diseases, reflux. I mean, could be the reflux that we might have treated for the reflux. And if you know, and if you identify that, for example, that if there's intractable cough, that we usually go by ABCD assessment, that is A for ARV inflammation, and B for there's in bronchial hyperactivity, you evaluating back, and then you go for cough reflex high sensitivity C, and D for this structural damage of the lung, and E for extra pulmonary comorbid conditions. So these are roughly ABCD approach for intractable cough. So if you identify this compound, and if there's nothing can be treated, and if it is due to cough reflex hypersensitivity, I think the option would be to go for cough suppressant in this case. But antifibrotics for cough is not a good option. I'm sure that my colleagues here in the audience as well as in the panel would agree with me.
I think I would agree with Amila, because a lot of these patients with RA have airway diseases, small airway disease, bronchiolitis, and he brought in the issue of reflux and a heightened cough reflex. So I think a more comprehensive assessment will be needed. Adhan, we have Dr. Saunders online, so maybe you can direct your question on hypersensitivity pneumonitis to Dr. Peter Saunders.
Yes, Dr. Peter Saunders and Dr. Adhan. This is regarding the use of upfront antifibrotics in chronic fibrotic HP. The natural history data from the chronic fibrotic HP shows that there is 60% of the fibrotic HP will be progressive. So currently there is no evidence that antifibrotics could be used upfront. But my worry is that if we wait for the disease to be progressive, if the FVC drop by 10% to be classified as a progressive fibrosing ILD, there is a twice the increased risk of mortality. And when the FVC drops below 50%, they are mostly considered for palliative treatment rather than curative intent, a treatment with a curative intent. So that so therefore, I wonder whether the antifibrotics could be considered in the fibrotic HP phenotype as an upfront treatment.
Thanks. That's a really interesting question. In the UK, we'd be totally forbidden from using them up front because NICE, the body who control the use of high-cost drugs here, have basically used the inbuilt criteria for when we're allowed to start. What I would remind the audience, though, is that 10% variability of FVC is described actually over day-to-day variability. And thus, what we've done a lot during the pandemic is use handheld spirometry to demonstrate the 10% decline. And you just have to catch the patient on a bad day to have your 10%, and then the patient can start treatment. The other word of caution I would say is that the antifibrotics are fairly toxic. Both of the available drugs to us have quite a considerable range of side effects. And I would say in the population we're looking at, 1 in 3 patients will stop due to side effects. So using upfront would be more desirable if the side effect profile was kinder. And the hope is that as newer drugs come through, that the side effect profiles won't be as bad as they currently are. Clearly, there's a trial currently of nebulized pirfenidone, and that seems to negate most of the systemic side effects, but also newer agents hopefully will be better. So I think at the moment, it's probably not the best idea to start everybody on nintedanib. Remember, handheld spirometry is a very good way of demonstrating 10% decline quickly, and hopefully better drugs are coming.
Thank you. Do we have any more questions, or do we have time for 1 or 2 questions more? Anybody else has any question for Dr. Saunders? Amila, my question, a previous speaker mentioned about the tracking lymphocyte subsets in BAL in one of the case discussions. Does this have a place in designing your immunomodulating agent, whether you're going to move towards rituximab or tocilizumab?
Thank you so much. I mean, I don't have much experience on this actually typing of this CD program. I'm not sure, Peter, now we are doing this. At the time when I was in Oxford, that we were not doing this subsetting of CD4 lymphocytes in the BAL for therapeutic decisions. But I think that we broadly consider treatment depending on the lymphocytes rather than the lymphocyte subsets, but I'm not aware of this practice in the UK, and I'm not sure about that. I'm sure that Peter would be able to
Peter,
answer.
would you like to take that question? This is in relation to CTD-ILDs.
So to be honest, I would not routinely bowel anyone who has a well-defined CTD because I think it will not change their management. CT scans will determine whether antifibrotics are needed on top of anti-inflammatory therapy. The times that I've seen the CD4-CD8 ratio used is mainly for the diagnosis of sarcoid. So in the UK, generally, we're not bowling CTD-ILD unless there's suspicion of concurrent infection.
I think we are on time, and once again, on behalf of our College of Pulmonologists, I thank all the speakers for joining us, and Peter and Amila for finding the time for the Q&A session. Thank you very much all, and the audience for their participation.
That was indeed a series of thought-provoking presentations. I thank the chairpersons and the esteemed speakers. And now I cordially invite Dr. Amita Fernando to present our token of appreciation to consultant rheumatologist, Dr. Gunendrika Kasturiratna. And now let me cordially invite consultant respiratory physician, Dr. Vatsala Gunasinghe, to head over to give the token of appreciation to consultant respiratory physician, Dr. Amita Fernando. Thank you, chairpersons.